for giving me the honor to speak here, and also particularly a thank you and a happy birthday to Dr. Mutha. Today we're going to talk about extrapleural pneumonectomy. You'll notice that Bernie Riedel is also on these slides. I let him use my data for a talk, and we agreed that we could both use the presentation. So some of it is his. I'll whip through some of this fairly quickly. No current disclosures. Surgical technique performed almost exclusively for malignant pleural mesothelioma. You'll notice it's a simple pneumonectomy, except you not only take the lung, you take the pleura with it. So you dissect through the chest wall, through the pericardium, and take out the diaphragm. So it's a massive operation. Surgical technique, an en bloc resection of the lung, where you can see into the abdominal cavity and the chest. And then you replace it and fix it with Marlick's mesh. Population, most of the adult surgery we do now is for malignant pleural mesothelioma, and the operation itself has come into a little bit of disrepute. It may not help. 20% are minor things. Epidemiology, mesothelioma, seems to be you need asbestos in the past. Smoking helps. The incidence is beginning to peak. The United States has probably already peaked, but the rest of the world will peak a little later. There was quite a latent period, about 40 years from playing with asbestos to getting mesothelioma. Of interest, as I guess grade 1 and grade 2, we used to use asbestos powder for modeling, and now of course it's like poison. Poor prognosis with mesothelioma. You tend not to do well. Surgical survival. The best subgroup with the best survival is epithelioid with negative resection margins and negative extrapleural nodes. That's done by David Sugarbaker, who used to be at Brigham and Women's and is now across the road from us at Texas Heart. I knew him as a fellow at Toronto General. David Rice, where I work, he has about a 41% 3-year survival with everything looking good. Overall survival after extrapleural pneumonectomy is not all that good. Mind you, other cancers aren't all that good either. By histology, the epithelioid has the best survival, and that'll become apparent why I said that in a little bit. Morbidity and mortality is quite high after this operation. So, as I said, it's a massive operation. David Sugarbaker has here in 2004. Mortality of about 3.4%, atrial fibrillation 44%. Respiration, you've got problems with ARDS and aspiration, deep vein thrombosis, and you don't want patch dehiscence and hemorrhage. Atrial fibrillation, so this comes down to the actual doing of it. They're usually hypovolemic at the time they go into atrial fibrillation, so you end up with basically not much blood pressure. You want the defibrillator that leads on the patients prior to starting. That's the one to synchronize, except they'll use internal paddles if they have to defibrillate. Dr. Thacker back there, who really started them at MD Anderson, and myself, used to run diltiazem infusions on these patients to try to prevent atrial fibrillation. We've kind of abandoned that. It doesn't seem to help. Ventricular arrhythmias, the left extrapleural pneumonectomy is more likely than the right. Respiratory. We still use thoracic epidurals for these, even though our surgeons have gone away from thoracic epidurals, between T5-6 and T8-9. Originally, we were using 10 mics per mil fentanyl, which I really think is still a preferable solution, but now we've gone to 5 mics per mil with bupivacaine 0.75%. If you go above 0.75%, you tend to get hypotension. Low basal rates. One lung ventilation, obviously, double lumen tube wherever possible, and you want to pressure limit your ventilation because you do not want to blast out the patch. The bronchus itself is stapled under direct vision while watching with a bronchoscope to prevent the surgeon stapling something they ought not to. Respiratory, you prefer them extubated in the SICU. On our series, about 5% need postoperative ventilation. Aggressive and early physiotherapy, early mobilization, and epidural analgesia till the chest tube removal. Infection, antibiotic coverage, obviously. Vancomycin is probably nice even in patients who don't require it because they're penicillin allergic, but so we may end up giving ampicillin sulbactam and then an intraoperative dose of vancomycin, repeat dosing obviously, and a betadine wash of the pleural cavity. Dvt Prophylaxis, as indicated there. Fluid is delicate. Sometimes there's a lot of blood loss. You want to replace the blood loss, you want to give enough fluid. But you give too much, they'll go into pulmonary edema and ARDS. Too little, and you'll have strokes, MIs, and renal failure. So volume versus vasopressors. When the surgeon squishes the heart, you will have not much blood pressure. And they do that, as you know. Replace blood and coagulants as needed. Fluids, you want a relatively dry patient. My personal preference is to limit crystalloid. Back then I used to do a liter of Hextend. Now I would probably use a liter of albumin. Others would be low-dose dopamine or low-dose phenylephrine infusions to maintain blood pressure. Hemorrhage, and I say variable, it may be sudden and massive, extremely surgically dependent. Of late, our surgeons have become very good at this operation. It's become almost boring sometimes, and then it gets exciting. Exciting as in 20 or 30 units of blood. So we tend to always put in a 12 French triple lumen right IJ CVC. With one of our studies, which we're going to come to in a bit, we discovered that one of the complications you might get is that they rip the right atrium when they're doing a right extrapleural pneumonectomy, in which case you might suspect that you might want to clamp the SVC. If you clamp the SVC, your lines in the upper body don't do you much good. So we've added, if it's a right side extrapleural pneumonectomy, add a femoral 12 French line, which is just primed and ready and removed at the end of the case if not needed. Arterial line, obviously on the side opposite the EPP. Fluid warmer and rapid infuser is needed, but I tend not to hook those up because if you hook them up, you have a tendency to give too much fluid. Hemorrhage, as I said, surgical experience is a big factor. You want a fibrinolysis inhibitor. Dr. Thacker started using aprotein, and we used it till 2007, and then we did a study of it from 2004 to 2007. I think Dr. Mangano's paper was rather unfortunate. Carcuti's paper as well, probably unfortunate, and I believe aprotein is now back in Europe. But what we're currently using is tranexamic acid with about a 2-gram load and plus a gram an hour to inhibit fibrinolysis. We did a prospective randomized controlled trial of aprotein in extrapleural pneumonectomy, IRB approval, IDO 30203. Investigator initiated, because I'd done aprotein studies back in the late 80s in Toronto. And we did a blinded randomized control trial comparing aprotein at Dave Royston's high Hammersmith dose to placebo. The endpoints were estimated blood loss and survival. This was published in Cancer in 2009. You notice my colleagues are on there as authors. There we did find that aprotein decreased blood loss. Now we have the p-value 0.05 here. In actual fact, our statistician who designed it showed that we really didn't have to use non-parametric statistics if you used the fourth root of the blood loss. But he said when we did the study, said the blood loss is so secondary, we'll just keep non-parametric statistics. The real p-value was 0.028. These are the Bayesian log normal regression models for predicting survival times. You'll notice the things that had a beneficial effect: treatment, aprotein versus saline, with a 0.99 chance of being beneficial. As well, better to be male than female if you have a, and also you want chemo and intensity modulated radiation therapy. The statistician we work with is probably the world expert in Bayesian analysis. But what was interesting about the study was the Kaplan-Meier survival curve. When we wrote it up, it was fairly obvious when I gave Bernie the numbers for his talk that, oh, that's interesting. All the control group are dead. Our statistician looked at us and said, you don't need statistics on this. I want to be in that group. And so it was kind of interesting. So we published it in Cancer. And as Peter Thal, the statistician, said, you've just thrown a hand grenade into a room full of oncologists. We'll see what happens. And the answer, nothing. Nobody ever wrote a letter. Nobody ever complained. They just said, humph. This is better than any chemo drug I've seen. Now, if you do, we did a retrospective database review of our data from 2004 2006. If you look at the patients who were given aprotein, they did seem to do better. And you notice there were previous non-RCTs, at least they weren't looking at survival after liver resection, esophagectomy. The esophagectomy study is actually Dave Royston's data. Zimbler was in his group. Bernie Riedel, our colleague at the time, was actually Dave Royston's fellow. He said, I'm one of the placebo group. So aprotein may actually have a very significant antineoplastic effect. And it's kind of interesting it's coming back. Something that I'm involved with now, mainly because I end up doing 3 patients before we did a study, is intrapleural perfusion. I thought I'd say a few words about this, because doing this in conjunction with either a pleurectomy or extrapleural pneumonectomy in younger people who have usually metastatic osteosarcoma or sarcoma of other types. And it tends to be you have the horrendous extrapleural pneumonectomy followed by washing out the resultant cavity with cisplatin, the idea to kill any remnant cells. The perfusion is done with, as I said, cisplatin at 41 degrees Celsius. We originally used sodium thiosulfate to protect the kidneys against the cisplatin because it has quite a negative effects on your kidneys. We've switched to amifostine. One of my complaints with the sodium thiosulfate was you get a fluid load exactly when you don't want it, right at the end of the case. And so you give this great big hypertonic saline bolus. And I remember taking a patient to our pediatric ICU with the poor little girl coughing up pink froth all over the place, and the intensivist, who was not an anesthesiologist, was having a canary because I said, it's an easy airway, you could put a tube in if you had to, and he wasn't really happy with me, so I had to stay for a while with some CPAP and some furosemide till it went away. Anyway, the flow of amifostine, there are 3 pleural catheters. There's an inflow, an outflow, and a chimney. And that's the phase 1 study. Phase 1 is just a proof of concept. And we're slow. We're up to, I think, about 7 patients. The 4 before we started and 3, or 4 study cases and 3 before the study. The chimney tube is a water manometer and limits your intrathoracic pressure. So this is what it looks like. I'd like to thank David Rice for these pictures. I used to have pictures in my BlackBerry, and then we changed to iPhones, and the pictures went away. So quite a complicated setup with a cardiopulmonary bypass machine that actually delivers chemotherapy drugs. It is not putting the patient on bypass. And there's the up mess where I am. You can see the ice around the patient's head because you don't want to make the head hot. 1 lung. There are the catheters. And there's the chimney. Now, one of the lessons I learned with this, when we were doing one of the first cases, there was you can see the, actually I'll use my pointer, you can see the chest tube, which will be just used to, there's an inflow catheter, an outflow catheter, and a water manometer. Well, we weren't using this originally. And one of the cases, they started perfusing, and I had this sudden thought of deja vu. We've just gone on bypass. Because I've seen this many times. You go from pulsatile blood flow to a straight line. And as David Rice said later, you weren't jumping up and down. What was wrong? And I said, I thought we got a bypass, that I'd missed something. Because the young patients have such low pulmonary pressures, if you put any pressure in the chest on the right side, you compress the right heart, and there is no blood pressure, period. So we now have a water manometer, and you'll see that high-tech piece of tape. You want to keep that fluid level below, and the perfusionist keeps that fluid level below, and that's the cytotoxic chemotherapy. Interesting thing, I don't know if this will become a standard treatment. We get about 1 patient every 6 months who gets this. So we'll have a study done in about another 2 years. That's it.